FAVMI presents Unfolding Mental Illness, hosted by Saraswati Suresh.
Hello, everyone. FAVME, Family's Voice on Mental Illness, is back with another episode. We are the regional chapter of FaceMe India, which is Families Alliance on Mental Illness. With our episodes, we hope to reach family carers looking after their loved ones living with mental health disorders, families who want to learn about mental health, and help them build tools and resources. If you are a family carer seeking guidance, understanding, and looking for community support, please do subscribe to the channel Unfolding Mental Illness by FABME. I welcome Ms. Saraswati Suresh, founder of FABME, and my name is Dr. Sachin Kanorkar, founder member and director of FABME. Good afternoon, all. Our guest for the episode is Dr. Venkata Lakshmi Narasimha, assistant professor at the Center of Addiction Medicine, NIMHANS. He has completed his MD and a DM in addiction medicine from NIMHANS. He has an ISAM certification, International Society of Addiction Medicine. He has published 50 papers and has numerous citations. He is also an avid runner. He has numerous awards, fellowships, travel grants, the last being at AIMS Devghar in 2023, an early career psychiatry fellowship, an ISAM NIDA fellowship, and many more. We at FAMI want to thank him for his valuable time and expertise to speak on the topic today. Our topic today of today's episode explores the intersection of addiction and mental health. We begin by asking him for family carers and lay persons who are the audience of this talk today on the basics of addiction to get started. Thank you, Dr. Narasimha. Could you please help us understand what is the field of addiction psychiatry?
Okay. So first of all, thank you for inviting me, both Dr. Sachin and Ms. Saraswati. So addiction psychiatry as a field, at least in India, is people who are the doctors, also the psychologists and social workers and other specialties who are working to help people with addiction. So if you talk about the specialty, people who have done after their MD in psychiatry, who has done fellowship in addiction medicine and DM in addiction psychiatry. So these are the specialized training that is available in the field of addiction psychiatry. Along with that, the Virtual Knowledge Network NIMANS runs some online courses, especially for specialized training in addiction psychiatry. After this is not just for the doctors, but also for psychologists and social workers. So addiction psychiatry in India, at least, is a very new field, helping people with addiction. Subsequently, when you talk what is addiction means, the best definition is from the American Society of Addiction Medicine, what is meant by addiction. So what it defines is as a chronic, treatable, and preventable medical condition. So like diabetes and hypertension, the medical society, the field of medicine recognizes addiction as a disease, and which is a chronic disease. Like it requires treatment for a longer period of time, and treatable, which means that in general, how treatments for diabetes and hypertension helps, treatment for addiction also helps. Preventable, like how you can prevent diabetes from onset, also from hypertension from starting. Addiction is also something that is preventable. And the definition goes on saying that the vulnerability, that is people who are genetically at risk, who has family history of addiction, are at a higher risk. And it also emphasizes on the environmental aspects. So for example, some drugs are available in certain part of the country. So availability of drugs also is important. Also, it highlights the importance of life experiences. For example, people who have had significant life experiences in their life, they are also at vulnerable. And these interaction of these things, that is the genes, environment, individual life experiences, and the substance per se, brings in changes in your brain in such a way that there is something called as a loss of control over the substance that you are using. Also, in loss of control over the behavior that you are dealing with. So, leading to using of the substance or the behavior, despite you know that there is a harm that is happening. So, there is use of the substance continuously, and like any other chronic condition, the treatment, after the treatment there are lapses and relapses that keeps happening. So this is the broad definition of addiction that American Society of Addiction Medicine, which is a very comprehensive also, which incorporates all the learnings that we had about addiction in the last 50-60 years, all the research that was done in the area of addiction, the findings that they summarized and gave this definition of addiction.
Thank you, doctor. That was a wonderful definition. I think for all of us, within the span of 2-3 minutes, we have understood what actually addiction actually means. Uh, just wanted to take it further. That today people speak about addictions for gambling or internet, etc. So how different is the drug addiction and the other forms of addiction which we see in terms of behavior today?
So broadly, addictions are of two types. One is the substance-related addictions and the behavioral addictions. Substance-related addictions, if you see, again, there are broad classifications, but in general, there is illicit substances and licit substances. For example, licit substances, alcohol and tobacco. And illicit substances, there are other group of, again, that is politically determined. Some countries the cannabis is allowed, some countries it is not allowed, but at least in Indian context it is alcohol and tobacco comes in this group of illicit. And illicit, all the other drugs, cannabis, heroin, pharmaceutical opioids, cocaine, methamphetamine. So these are the common drugs, uh, substances that are abused. The other group is the behavioral addictions. As of now, based on the evidence, we only have two behavioral addictions that are that you can label it as addiction. One is the gambling disorder. The other one is the internet gaming disorder. So these are only two behavioral addictions that are recognized as addictions. For example, we keep talking about internet addiction, we keep talking about food addiction, we keep talking about work addiction. So all these things we don't have enough evidence to call that these are addictions. So uh, so what happens in addiction is that there is a neurobiological change that happens, which makes people lose control over the substances that they are using, which makes them to use in a compulsive manner, uh, which makes them use despite harm. So these kind of changes, uh, these kind of behaviors happen because there is a change in your neurobiology. So that kind of change is observed with only few of these conditions. It is not commonly seen with other behaviors. So that's why it is not reached to an extent where you call it as a behavioral addiction like pornography addiction, sex addiction. So people give names for various other behaviors, but these are in general not labeled as uh, addictions in the contemporary scientific literature.
Thank you, doctor. That was enlightening because we all normally use this vocabulary, and I think we always confuse what do you actually mean by addiction. Is addiction and moral failure? Does a moral prism help uh, while addressing addiction?
Yeah. So the moral view of addiction has been there for centuries. So for time, for more than centuries, if you see all the literature, historical literature that has been written, addiction has always been, has most of the time seen as a moral view. But at least in the last 50-60 years, uh, things have changed. Things have changed, and people started looking from uh, a disease model. So once you start looking from a disease model, the stigma associated with addiction reduces significantly. Second thing is, when it comes to the moral view, most of the time it is associated with punishment. So most of the time it is associated with labeling that you are a bad person. You are a If you come and see the uh, hospital that we have, in a day around 200 people come with addictions, and most of them wanted to stop. They come to hospital because they wanted to stop substances. Hardly you will see around 10 or 15 has been brought forcefully by the family members, but eventually when they have the discussion with the doctor or the psychologist, their motivation changes. But most of them wanted to stop, but they find it difficult to stop. So that's where they come for the help. So at least in last 50, 60 years, we now know that addiction is something that is biopsychosocial. So there is a biological angle, there is a psychological angle, there is also a sociological angle. So it's a component of all the three things that contributes to addiction. Also, that helps if you wanted to help someone to come out of this addictive process. You also need to work on these three angles. So you need to help them with medicines biologically. Psychologically, you need to help them to overcome their uh, difficulties or help them to find a purpose or meaning in life. Also, sociologically, there are a lot of effects that these substances cause, particularly at a family level, at a community level, and helping them to overcome those challenges is also very important. So, the moralistic view has been changing, has been changed in many across. Even, for example, there is a community program called as therapeutic communities. So earlier, it was looked in a moral angle. Now even therapeutic communities where we even have, for example, there are local uh, uh, treatment centers which are run by the uh, what you call the temple trusts, also some Christian missionaries. So these treatment centers also do have a medical doctor who comes and treats them. So which was not something that was there at least 40, 50 years back. But now there is awareness across the communities also in the treatment settings. But this awareness is very minimal and it has to be increased. Only people, when they come in contact with the treatment center, then they realize that okay, there is a medical angle to it. But in community, for people's awareness about that, yes, this is a disease and this can be treated, is still very less.
Thank you, doctor. That was very comprehensive. What are the early signs of addiction friends and family should look out for? And I just wanted to add one more angle of, as you rightly said, is the religious connotation in our culture of maybe consuming cannabis or being related to uh, of a drug which is consumed by a god. So, what should the family actually look out for uh, when to look out for early signs of addiction?
Yeah. So in general, there is addiction is a spectrum where there is a use, then there is a harmful use, then people go into a dependence pattern. So people generally people may go through this spectrum, or people can directly go into a dependence without without going into this transition phase. Um, so what happens is what how people transition from this use to dependence is very different from person to person. So, for example, people who have risk factors, they are at a higher risk of transition from this use to dependence. For example, if you have a family history of dependence, okay, that is at a high, that increases the risk. If you have some adverse life experiences, so I have been using alcohol on and off. Suddenly there is a event which is a very significant event, and alcohol was always there in the picture. So then the chance of you becoming addicted to that substance increases significantly. So the early signs are when people increases the dose of the substance that they are using. For example, I've been drinking once in a week, so my drinking quantity has increased. Second is my uh, uh, instead of apart from quantity, I have been drinking on a daily basis. So that is one. Second thing is loss of control. So this people will be able to understand when they think that they are going to drink only a peg of alcohol, but they end up drinking 4 pegs, 5 pegs, and they pass out. So loss of control is one important indicator that you are going into an addiction. Then there are harms that are happening. For example, uh, I am drinking and driving. I have been caught. Even then, I continue to drink. I have been there has been episodes where I misbehaved with some of my friends when I am under the influence of alcohol. So I am continuing to have harms, both physical. I have been having gastritis, but still I continue to drink. So even despite I am having physical, social, psychological harms, but still I continue to drink. So that's where people need to be cautious that if there is loss of control, if the use frequency and quantity is increasing, if I'm using despite harm, then people should caution themselves or family members should caution the others that there is a problem that is happening. So in general, what we have seen is that there is no need for you to become dependent on substances to sustain harm. So even if you are using recreationally, then also you can have harms. We have seen a lot of these things with cannabis because you brought up this cannabis uh, because you told it is consumed by gods. At some places it is called as Bhagwan ka goli, Baba ka prasad. So these are the common some of the common names that are used. There is a difference between bhang versus uh, weed. Bhang is something that is made of leaves, and the THC content is very low. So it is very low. Do you think that we should continue? We should consume? There are even people when I sit in an OPD. There are people who used to come with using of these bang golis or the bang lassi and having panic attacks, and these panic attacks continued for a prolonged period of time. So any substance is associated with harms. Uh, in the same way, cannabis also has been associated with harms. As I was telling that single episode use, many people when they get job in Bangalore, that's when they get an opportunity to because they have money. Again, this is purely on some patients' experiences that I'm sharing. Uh, they have money and they have all the opportunities to use drugs. So when they experiment on these drugs, there are a lot of people who develop psychosis in the first 1 or 2 weeks of using cannabis. So there are harms that are associated with weed also. So there is harms associated with bang also. There are harms associated with weed also. Even right now, especially in the countries where cannabis has been legal, one of the major problems that people are facing is that there is tremendous increase in the potency of the THC in the cannabis, which is leading to even further harms. The other important aspect is people who already have a diagnosable mental condition like schizophrenia, bipolar. When they use this cannabis, the harms that they sustain, not only because of cannabis, because of the worsening of the other mental health issues, is tremendously high. I hope I answered your question.
Oh, no, thank you, doctor. This is very, very nice. And especially what you mentioned earlier, the political scenario plus the kind of glamour drugs attract, the religious connotation, the peer pressure, the religious connection, and the society right now in which we're existing, where there's a lot of clash of all these points happening. Thank you for the basics. Now I would request Saraswati to take over the discussion, where she would deep dive into the intersection of addiction and mental health. Welcome, Saraswati.
Thank you, Dr. Sachin. Thank you very much. So moving on to the next question, sir, is How do you think addiction and mental illness usually intersect?
Yeah. So we call it as a shared vulnerability hypothesis. So, for example, people with addiction, and addiction itself is a mental health issue. So, addiction is under the division of mental health, uh, both in ICD-10 and ICD-11. So, addiction itself is a mental health disorder. So, most people have a shared vulnerability, which means that if I'm at a risk of developing addiction, I'm also at a risk of developing schizophrenia. I'm also at risk of developing bipolar. I'm also at risk of developing depression. Uh, how do you uh, how do you prove this? So there are common genes that are associated with both addiction and also schizophrenia and bipolar. So this is one hypothesis that people with addiction are also at risk of mental illness. Epidemiologically, also this is proven. For example, people with schizophrenia has almost 40% of comorbidity with one or the other substance use disorder, and people with substance use disorders like alcohol use disorder, so they are at a comorbidity of around 30 to 40% risk of other mental health issues. So that can be ADHD, that can be schizophrenia, that can be bipolar, that can be depression. So the comorbidity between substance use disorder and um, addiction is also high. Sorry, substance use disorder and major mental illness is also high. There is another hypothesis. The other hypothesis is, for example, people with major mental illness like schizophrenia. So they start using substances because of the symptoms per se. For example, people with schizophrenia has uh, emotivation. So they start using substances because of emotivation and start using cannabis as a self-medication hypothesis. So that is one another explanation why this comorbidity exists. The other hypothesis is that people with schizophrenia also do have also have an effect on their frontal lobes, which affects their decision making, which uh, makes them use these substances. So that is the other hypothesis. This is called as sequential disorder hypothesis, which means that after one disorder they start having other disorder. Other way around, if you look at people with cannabis use or people with alcohol use are at a higher risk of developing schizophrenia or bipolar disorder. Why? Because cannabis precipitates, if you are genetically vulnerable to develop schizophrenia, cannabis brings forward schizophrenia by at least 3 years. Again, this is all research based that if I am supposed to develop schizophrenia at the age of 25, so if I start using cannabis very young, then the chance of me developing schizophrenia will be at 22. So that is another thing that has been proven in research. As you increase the dose of cannabis, the people experiencing psychosis because of cannabis also uh, increases significantly. So there is a dose dependent. There is also a temporal relation between cannabis use and psychosis. So this is the broad intersection. Again, there are for each substance there is an explanation for, and there is a differential level of comorbidity. For example, if you see childhood illnesses or neurodevelopmental disorders like ADHD, so people with ADHD are at a very high risk of developing substance use disorders. So if you treat ADHD when you are a child, your functionality improves during your childhood, and your chance of developing substance use disorder comes down significantly. But if you don't treat childhood ADHD, then the chance of you developing substance use disorder is high. Again, there are some longitudinal studies also to support this.
That's very interesting what you are explaining to us. I don't think a common person or a common parent is aware of, such aspects, truly. So, what comes first? Does the addiction come first or the mental illness comes first?
Yeah, that's what I was telling, that the hypothesis is both. Right now, at least from the evidence that we have, it is a shared vulnerability hypothesis, one hypothesis, which means that both are determined by same genetic makeup. The other hypothesis is sequential, so one is leading to the other. So that's what we as researchers are trying to see whether which starts first. But at least right now, both the hypothesis seems to be true, that there is a shared vulnerability between both the disorders, and there is also a chance that these happen sequentially. Like, for example, people with schizophrenia have something called as prodromal symptoms. So, where they have anxiety, they have depression, they have thoughts which are still not yet developed to into a delusion kind of a thing. So, in this anxiety, they to relieve their anxiety, they start using cannabis. So once they start using cannabis, the cannabis precipitates an episode of schizophrenia. So is it because of schizophrenia people started using cannabis, or because cannabis they are using the schizophrenia has been precipitated? So there is a debate that is there, but to our understanding, both are through a shared vulnerability, that is through genetically determined or predisposed by certain set of genes.
Yeah, thank you. Because this is often the question which is there in the minds of people, what starts first, whether one is acting as a catalyst or whether it's because of this. And I think it always plays in the mind of the family carers.
Yeah, let me also give one more example. For example, you see at 25 years of age, a boy presents with cannabis dependence, and there is also ADHD comorbidity. What happens when there is an ADHD in childhood? So when you are 4 years, you get into trouble with your friends at school, then you are someone labeled as a troublemaker. So at 8 years, you are someone who drives bicycles very fast. You don't sit for studies. Then you are again labeled as a deviant peer. So the main peer group whom you are supposed to mingle, you are not mingling with the main peer group, and you are always mingling with the so-called deviant peer group. And at the age of 12, you are driving bikes very fast. You are taking impulsive decisions, and you also started drugs very quickly because the so-called deviant peer group has access to drugs, whereas the main peer groups are involved in education into a structured routine. So once you are out of the structured routine, once there is an opportunity where you can start using drugs, you start using drugs when you enter your adolescence, where you have access. So you are seeing at 25 thinking that there is cannabis dependence and there is also ADHD. But if the same ADHD was treated when you are 4 or 5, so you are into the structured group. So you are not labeled as deviant. So you have been in the system, and your access to drugs is minimal because you are not become deviant or got into the deviant so-called deviant peer group. So that's where whether if we have prevented or if we have treated ADHD early, we would have prevented, maybe we would have prevented the substance use because the comorbidity is very high. So that's a example.
Yeah. Yeah, that's an interesting, I'm sure our viewers will be, happy to hear this also. I mean, you take preventive steps right at the beginning.
Yeah.
Yeah. So, what are the common mental disorders which are related to addiction? Is it only, as you said, ADHD is one of the steps. Besides that, what else are the common mental disorders?
Common mental disorders are the common mental disorders. So we call it as severe mental disorders and common mental disorders.
Correct.
Generally, the common mental disorders that are associated with addiction is depression and anxiety. So these are two common things that we commonly see along with addiction, and especially in very common in India, but very common in other countries is the pain disorders. So people who have, especially in the elderly population, when they have pain, uh, using other substances like opioids is something that is common in other countries, but at least in India, you don't see such kind of thing. Along with that, the ADHD is something that is commonly associated with substance use disorders. And major mental illness is not, I cannot tell not, but it is associated with the prevalence rates varies, especially when it comes to major mental illness with the different substances. For example, cannabis, it's significantly higher. Again, these are the people who are dependent on this cannabis. For example, there is research that if 100 people try cannabis during their adolescent, only 10% goes into a dependence. Rest of the 90%, they try and they leave it there. So it doesn't mean that they have to try, but this is what the research tells, that not everyone who tries this substance goes into addiction. The proportions are different. For tobacco, it is very high, around 30 to 40% become dependent. For alcohol, around 10%. So these are some of the stats.
Interesting statistics, I would say. Yeah.
Yeah.
So, how is what is this dual diagnosis of addiction and mental illness? How do you all go about the treatment? And what are the emerging trends now in the market today in terms of treatment?
So the dual diagnosis generally you call when there is a substance use disorder along with the major mental illness, the severe mental illness, that is schizophrenia, bipolar, and major depressive disorder. When you have these conditions, then you call it as a dual diagnosis. Again, this definition is something that has been extended, and people also include the common mental illness into this definition. So the problem with dual diagnosis is that you have to treat two conditions. You also need to treat addiction. You also need to treat severe mental illness or other common mental illness. So treating one is generally easy, but when you wanted to treat both, it becomes slightly challenging. Why it becomes challenging is, I can give some examples. For example, people diagnosed with bipolar, so they are put on medication. For example, they are put on prophylactic medicine called as lithium. So as soon as they consume alcohol, they stop this medicine. Once you stop this medicine, your risk of developing uh, bipolar increases significantly. So that is one example. Second example is, for example, people with schizophrenia. So they are put on medicines like clozapine. So you are also a person who smokes. So your dose of medication has to be increased significantly to an extent that which could be actually treated without. If you are not smoking, your doses will be slightly on a lower side, because smoking actually alters the metabolism of particular medicine. So these are some of the challenges that when you have a dual diagnosis and you need to manage the dual diagnosis. And it also becomes challenging for families also, uh, because for families, one having a disease itself is a burden on the family. When you have disease along with second disease, that becomes a double burden. And because of the second disease, if the first disease worsens, it becomes very challenging for the families. And again, in India, families are the biggest support, which takes care of people with mental illness, also in substance use disorders. And it actually affects across the socioeconomic status. You talk lower socioeconomic status, upper socioeconomic status. There is no what you call difference in terms of how families suffer because of the burden on families because of both substance use disorder or major mental illness. And when there is a dual diagnosis, the suffering is double.
Yeah, in fact, parents, I would say not only parents, but any family carer for that matter, is always facing this challenge, what should be treated first, whether it's the mental illness or the addiction. I think they keep going through this challenge always.
Yeah. So at least in India, it is more or less we treat both, because rest of the world there are a stepped approach. So first I treat substance use disorder, then I give a referral to for management of major mental illness, or I treat major mental illness and send it for treatment of substance use disorder. But at least good thing is that because we are we are at a very low resource setting in Indian context. Generally, what people do is people treat both. Specifically, for example, uh, if I have to tell about the uh, patients that I have seen in last 1 week. So people have come with cannabis-induced psychosis. So we admitted them, we treated for psychosis, and as soon as the treatment for psychosis getting down, we started working with the families about cannabis, and then once the insight has improved, we started working with the patient about the how do we prevent cannabis from relapsing. So it's a comprehensive treatment, but the only challenge that comes is when there is a psychiatric illness, that is the major mental illness or schizophrenia, bipolar, the receptivity for substance use interventions will be slightly on a lesser side. So generally, we try to uh, help them recover from the schizophrenia or bipolar or depression, and then start working on substance. That might be different for example, people with alcohol dependence and depression. So once we treat alcohol dependence, generally people don't require the antidepressant. So they also do come out of the depression spontaneously. So it depends upon the disease per se. But in India, it is you treat both, especially when people are coming for an inpatient admission. In outpatient admission, also, as soon as the person recovers from the one illness, the other illness also will be addressed.
Okay, so it depends on the call is taken depending upon the disease and the addiction levels. Yeah. Okay. So, and what are the emerging trends in the market today for treatment?
You mean to say in terms of the treatment strategies?
Mechanisms and the strategies?
Yeah. So, in terms of medicines, there are not many new medicines that has come up in the last 5-6 years, but there is a lot of research that is going on in terms of developing newer medicines. For example, there is a newer medicine for diabetes called as GLP-1 antagonist or agonist, that is semaglutide. So semaglutide has been studied extensively right now, also being studied for addiction, because there is a relationship between your glucose metabolism and also addiction. That is something that is being researched at this point of time. There is also a relationship between your food intake and addiction. So there are certain drugs called as orexin receptor antagonists, which are approved for sleep. Those are something that is used for right now research for addiction. There are certain anti-craving agents that are already available in the market, which are approved by FDA and which are very commonly used for alcohol, for tobacco. So these are certain things already existing, and there is also research going on. Right now, we are also working on brain stimulation. So we know that there are certain areas of brain which are actually involved in craving. So we have newer non-invasive brain stimulation methods like RTMS, transcranial magnetic stimulation, TDCS, transcranial direct current stimulation, which stimulate certain areas of brain which are involved in craving. So once you stop substances, you start getting that craving, an urge to take these substances. So these brain stimulation methods stimulate the particular area of brain which actually reduces the craving and helps people to not relapse to substances. So that is the newer emerging thing. There is also some evidence for tobacco on e-cigarettes, but the problem is there is also tobacco industry interference on these e-cigarettes, which makes it slightly complicated whether this evidence is promoted by the tobacco industry or is it the rich evidence, scientific evidence. Again, at least in Indian context, it is banned, so we need not break our heads whether to give e-cigarettes or not. But there is a controversy on e-cigarettes.
Okay, so what about but with e-cigarettes, there has not been too much of research which is available in
No,
India?
there is a lot of research. There is a lot of research. There is Cochrane level of evidence, but there is also tobacco creating these e-cigarettes. Whether the the dilemma is that, for example, the problem e-cigarettes is a double-edged sword where there is evidence that e-cigarettes are helpful. On the other hand, there is also evidence that e-cigarettes are harmful. How it is harmful? Adolescents who never started any substances started with e-cigarettes. So that is one. Second is when it comes to e-cigarettes, people who take e-cigarettes, the quantity of nicotine that they are consuming has been increasing significantly, and they are going into a nicotine addiction. So that is the other challenge. So like this, there are some challenges, and the tobacco industry always comes up with newer things. For example, there is heated tobacco products, which means that there is no burning of the tobacco products. It is only heating. So you get the kick, but it is devoid of carcinogens, is what is being promoted as. But we really don't know what are the facts of uh, in a long term. What are the consequences that? So these are all very debated, and even government has an warning that this should not be discussed in a public forum.
What about cannabis? What is the research on cannabis, which is
So
the
cannabis,
biggest challenge which parents are facing in today, the youth,
yeah,
because it's legal in some countries and it's not legal in some countries.
that is very true. That is very
And
true. And
it's now taken over from the youth, it's taken over the alcohol story. So what is research talking about cannabis?
yeah. So that's not just challenge for family members, that's challenge for doctors also. Because day in and day out, when we sit with adolescents, this is the common argument that we hear, that cannabis is legal in so many countries. So there is a difference in terms of legal and decriminalized. So many countries it is decriminalized, which means that if at all you are caught with cannabis, for example, in India you will be fined and you can also be jailed. For example, I am using cannabis. I can be, if I am caught using cannabis, I can be jailed and I can also be fined, even if I am not dependent on cannabis. So in many countries, what they have done is they have decriminalized cannabis. Only a few countries have legalized recreational use of cannabis. Not many countries have legalized the recreational use of cannabis. But there is also a lot of research that is happening on medical cannabis. And most of the research is happening on, see, cannabis has around 70 chemicals within its plant and even more. But identified chemicals are around 70, out of which THC is the component that gives you high, and CBD is a component that is anti-anxiety. So most people use cannabis because of the THC. Many people don't use cannabis because there is CBD in it. But most research that has been done is for looking at the benefits of this CBD. So even in India, CBD is available at this point of time. You can prescribe a person CBD for approved indications. For example, you can prescribe CBD for epilepsy, resistant epilepsy. You can off-label it has also been used for anxiety and sleep disturbances. So CBD is available in India, but if someone tells that I am using cannabis for anxiety, if I tell that I will prescribe you CBD, why don't you use? Many people don't like it because it's not just for anxiety. It's predominant reason why they use cannabis is to get the high, which is the THC. THC gives a high. How do you get a high? Because it acts on dopamine. THC also causes harms. Why? Because when it causes harms, THC causes psychosis because it also acts on dopamine receptor, which is at risk of developing psychosis. So the the harmful product is the product that gives you high. So there is also some research where they are putting a little bit of THC along with CBD, but the proportion of THC is extremely low when they do research. But that research has not materialized in terms of coming up with indications that this is what uh, it has to be used. The other thing is people who tell that I am using cannabis for getting these benefits, they never know what is the THC and CBD quantity in there. So the drug sellers, when they sell very high potency of cannabis, which earlier it used to be less than 1%. Now there are research that shows that 16%, 20% of THC in the cannabis, which can lead to harmful effects.
How do you convince the patients then?
At least some people get convinced when we have this kind of a discussion. And most of the time, people, when they use this, they feel that their creativity is increased. But in general, they are creative people. So when we have this kind of a discussion that about the creativity part, they also do reflect that they were creative even without cannabis. So that is one thing. Second thing is most people, when they have this vulnerability, people who are impulsive, people who have this ADHD, they are the people who generally tend to experiment on things. When we give this, when we reframe that cannabis is not your problem, your impulsivity is a problem. So then people tend to understand that let's work on the impulsivity part rather than working on the cannabis part. So then people are happy. The other thing is when we tell families that most of the time, some of the times families come with that they have been using cannabis, but they are not dependent on cannabis. When they reassure family that there is no dependence here, they might have recreationally used. So that time also families get convinced a bit. So it's an individual to individual basis. There is no blanket approach.
Can you please explain to our audience about relapse and how it fits into the recovery process?
Yeah. So when, for example, I am using alcohol on regular basis and I decided to stop. So I came to the hospital. I got admitted in the hospital, and I got treatment, and or I got treatment on an outpatient basis. Now I am abstinent for last 3 months. I have not been taking alcohol for last 3 months or cannabis for last 3 months. Suddenly, my friend has come from Delhi and asked me, "Chalo, let's have one drink because we have been drinking for ages, and now you decided to stop. I'm very unhappy that you have decided to stop." I tried my level best based on the counseling that I received in the hospital, but on that occasion I could not resist myself and I had the drink. So that one drink that you had is called as lapse. But we know from addiction that lapses lead to something called as a relapse. So many people, once they have that one drink, they end up having on a daily basis or the previous pattern that they used to have. So that lapse quickly transforms into something called as a relapse, which means that they are drinking or using substances in the previous pattern at which they are using. So this we call it as a relapse. So even when we are helping people with addiction, we explain to them that, like for example, the analogy that we commonly use is that if you have diabetes and you are asked to not eat laddu, so there might be an occasion where you end up eating laddu because you went for a marriage function, which is very common, and you might also have a lapse. So understanding lapse and preventing it from going to relapse is a very important thing, and that becomes an important part of our psychological interventions that we do. This is called as relapse prevention therapy, which is the most common therapy that is used across the world and also in India to help people to identify what precipitates these lapses and what precipitates these relapses. Again, there are multiple factors that precipitate lapses and relapses. Some are internal, like negative mood state, low frustration tolerance. Some are external, like I was telling about friends coming and a sense of accomplishment that happens. So there is a big hike in my job salary, and so there are various factors that precipitate these lapses and relapses. So in the counseling or in the intervention that we provide, discussing about these lapses and relapses becomes an important part of the treatment.
So moving on to our last question, it's because our audience is primarily family carers. Uh, Both ways, how do you think the family should support their loved ones? At the same time, since it's a double burden for the families, as you mentioned, what are their coping strategies they should follow? What would be your advice to them?
Yeah. So again, it varies across families. There is no blanket approach how we can how the treatment settings support family, how families support each other, how an family copes with the uh, burden that they have. So it's there is no blanket approach, but at least I will share from my experiences. For example, you see from uh, a particular problem like intimate partner violence. When a person is using alcohol, there is a lot of intimate partner violence that happens towards the opposite gender. So one thing that we tell people is, or help families is to empower them to seek help when there is a intimate partner violence that happens. So that becomes very important thing for families. Second thing is we also discuss with families. You are talking about the relapse. Once the relapse happens, how do they handle? So we make a plan for them. We make a supportive this thing for families, how they can bring the patient to the hospital setting or help any help in case of there is a relapse. Uh, we also have a family groups that happens once in a week. People who are admitted in the hospital, people who also come to the OPD. Once the family comes, so there are certain family groups that happens. So these family group sessions are extremely useful because they it provides them an opportunity to share the problems that they are facing, especially in the context of addiction in the spouse or children uh, or even children bring their parents for addiction related problems. So there are various other strategies. For example, we have a telemanas helpline number 14416. So many families do call this telemanas helpline that this is the problem with my son, this is the problem with my father, this is the problem with my husband. I'm finding it difficult to handle. So that's where the help. So this is a national helpline number that people can access toll free 24 into 7. And there are people who access this help through telemanas. The other component that we also do with families is once we identify the distress with family is significantly high, we have a team of social workers who work with these families individually. And today we were having a case discussion where uh, we found that addressing family is also important in terms of helping recovery. So we have family therapy for the families. So it's a multi-pronged approach and it is again individualized. So there are certain things which are easily available. For example, telemanas is something that is very easily available. But if you wanted to go into more specificities, there are these kind of services available. Now, to ease families, digital technology is something that we are using it. For example, patient comes all the way from West Bengal to Nimans. It is a lot of expenditure for a family to bring a person who has not been earning for some time. So with digital technology, we have tele follow-up services. So family need not spend a lot of money to travel till here. So we provide interventions from uh, Nimans to West Bengal. So these are for people who are already under treatment from camp. So with technology, there is a lot of progress, and our mental health education department, along with PRS, Psychiatric Rehabilitation Services, they have been instrumental in developing a lot of resource materials, particularly to support families. Especially when you talk about addiction, when there are harms that are associated with alcohol. For example, people develop cognitive impairment because of alcohol, so they get some disability assessment and benefits to support families. So it's a kind of you have to work where we can help with families, how we can support families. So yeah, the approach is multi-pronged.
Yeah. I think that's the need of the hour for the families too, because they also go through it's a journey for them too when they have one of their loved ones suffering from both addiction and a mental health disorder.
Yeah, that's a really a challenge. It's a challenge for doctors also
Yeah.
because many places when you come to training in terms of addiction, although the training for severe mental illness is okay, but when it comes to addiction, the training is also minimal at certain places. So when when they see dual diagnosis, it becomes challenging for the doctors what to address, how to address, and when to address.
Yeah. And thank you so much for your time. And it's very important for families to know also that addiction is a disease. I think
Yeah.
that's the biggest learning which one has taken from today. And, people do the preventive mechanisms right from the beginning. Yeah. Thank you so much for your time, sir. Totally appreciate it.